Welcome to How to Precept in the EM, a PA Roundtable. We're so excited you guys are here. We're just going to give a few extra moments for attendees to come in, and then we'll go ahead and get started. We have an awesome panel today, so I'm really excited for all the things that we're going to be able to share. Give it a few seconds here if everyone can kind of come on in. I was told to count to 15 Mississippi in my head, and I'm at like 11, even though I probably just lost count by talking again. So we'll just go ahead and get started. My name is Katie Iverson, and I am a PA, and I'm the education team chief of staff here at Hippo Education. We all know this, but precepting is one of the most powerful ways that we can give back to the PA profession. Yet being a skilled clinician does not automatically make someone a really skilled teacher. Today, I'm super excited that we have 5 experienced PA preceptors who will share the best practices for teaching on the go, tips about how to balance efficiency with education, and ensure that both the preceptors and the students can thrive during the clinical rotation. So whether you're preparing for your first student or you're looking to refine some of your longstanding approach and your skills, we hope that you pick up some practical strategies from this and a renewed sense of confidence that makes precepting really rewarding experience for you and for your students. Just a reminder that for those watching live, you can claim an hour of Category 1 CME for this, and you'll get an email about this tomorrow, along with the information about how to get that CME. And then there will also be information about our Hippo and SEMPA partnership, which they're really excited about our partnership, and we have some really special product offers for SEMPA members. And before I introduce the panel, I have to let everyone know that none of us have any disclosures, so nothing to disclose here. And let me just tell you who we have. So again, I'm Katie. We have Jeremy here as well. He's been working in the ED for 15 years. He's been precepting for about 13 of those. He also works currently at PA Education. We have Ashley. She's worked in the ED and the urgent care for about 3 years. She's worked in primary care for 11, precepted for 8 of those. Currently works in family med, and she works at Hippo Education with myself. We have Tanel, who's been in the ED for 9 years, precepted for 6 of those. She's the lead APP where she works and been on PA faculty for 6 years. Dana has been in the ED for 17 years and on PA faculty for 13 of those. And she's also the lead APP educator where she works. And then Margaret's been in the ED for 6 years, precepted for 5 of those. She is the PA student clerkship coordinator and a clinical assistant professor in education where she is as well. So we're so excited that everyone's here to talk about your experiences and to give us some tips and some tricks and to help us feel more confident as we precept. So as we get started, I know it's easy to become a preceptor when you're affiliated with a PA program because you're there and you know the need and you know that they work there and they're easy to send you folks. But what about someone who wants to start precepting but isn't connected with a program? What would you say the first step would be?
I would say for that, the first thing that you can do is actually just reach out to your institution. Find out if you're actually allowed to precept. A lot of systems will have an education department, and those departments can be really instrumental in helping ensure that there's an affiliation agreement, which the program will need, and also to kind of help you navigate if they require any particular onboarding before students can come. The other thing is, PA programs are popping up like daisies. There are currently 321 accredited programs. So the other thing you could do is you could actually just go ahead and Google and see if there's a program nearby. We're actually going to provide a list of current programs because the thing that you could also think about doing is if you Google and find that there's one nearby, you could actually reach out to that program directly and see about getting hooked up with them.
I want to live where you live, Tanel, because where I live, the dandelions pop up, not the daisies. I want to live where
No,
daisies
it
pop
sounds so
up
much
because
more beautiful if it's
it's
days.
so much more beautiful to have daisies pop up than dandelions. So what advice would you give if someone says like, oh, this sounds really great, but I just don't think I'm ready yet to precept. I need another year. I need another 2 years. How am I going to ever feel ready?
Yeah, that's a great question. I know first things first, wait at least a year in your specialty. You've got to get on your feet. You've got to understand what you're doing and have some grounding. After a year, again, some of you may be 6 months, some of you may be longer than a year, but after that, when you're really starting to get interested in it, or maybe a program has asked you if you would precept, talk to your trusted colleagues, right? Ask your PA friends who precept, ask physicians that you trust to give you honest feedback and find out what they think. That's exactly how I got into precepting. I didn't have any faith that I could do that. And they told me I could. So I started and it went really well. Did I know everything about the specialty? Are you going to be the guru in emergency medicine? Probably not. But you don't have to be a know-it-all to have somebody learn from you. And in fact, precepting, you get to learn alongside your student, and it becomes this kind of mutual benefit, right? You have somebody there with you, you're teaching, you're explaining what you're doing, it makes you better at what you do. So I think that's a really good way to start, right? Just knowing that you don't have to have all the answers to start, and then just making sure that you feel comfortable and others think that you're good enough to do that.
Yeah, I totally agree, Jeremy. I think something too that's important is that, like, if you're expecting to be a master before you start precepting, you are never going to get there. Like, no one is truly a master of emergency medicine or really any specialty, right? But also, like, think back to your own preceptors, to like what, like, the people who are approachable and supportive and like willing to share their thought process. Like, a lot of that doesn't actually have to do with clinical knowledge. It makes people really, really good and successful preceptors. I also think sometimes, right, like in a perfect world, we're like very EM bias in this group, but there's a lot for us as EM people to teach students who are even not going into emergency medicine. So, like, this is how like communication and teamwork and procedural skills and clinical decision making works, right? And also, I think it's really important, like, students have to figure out, like, can you hang on nights and weekends and rotating schedules? And so ultimately, precepting is like less about perfection, but more about like the perspective that you're able to share with your students. So, seeing like what it's like to actually practice and navigate that from, a real world PA is super beneficial to students. And I think that you'll find not only beneficial to them, but like you said, Jeremy, to like yourself and sharpening those skills and confidence in the process.
I think those are such great points, Margaret. And I agree with your comments about readiness and kind of jumping in. I think one of the things that gives people hesitancy and I get the most questions about is how it affects your efficiency. And I would be lying if I say that it doesn't initially. It absolutely does. But that was kind of short lived, and you totally get into a flow with students and you find a groove. And over the time, I actually have found that I can sometimes be even more efficient now that I have students, as opposed to seeing patients independently. I feel like I'm actually seeing double the amount of patients. Like they're seeing somebody and I'm seeing somebody. And I think one of the ways that I got into this point is to think outside of the box of the classic, like, student goes and sees the patient, then the student speaks with me, then I go see the student, then we write a note and get a plan, of kind of being more integrated in your approach and asking students to do things when you have other work to do. So like a small tip I would give is, like, if I need to go see a patient that they're not involved with, I'll say, like, hey, can you do a chart dive for me and see what that note on cardiology wrote? Or can you trend their CBCs for me so I can come back and we can connect on that? I'd be interested to hear other thoughts on efficiency. Ashley, how do you stay efficient?
Yeah, I love that idea of like giving them tasks while you're maybe busy doing something else. I do think that the efficiency is the biggest concern that I hear from my colleagues. Like they don't want to precept because they're worried it's going to mess up their flow. And it certainly can, like you said, Dana, like especially if it's the student's very first rotation, like it's going to be slower, but you just have to figure out how to kind of bring them into the fold. The other thing that I think is important to know, at least that I've seen on some of my Qualtrics scores, is that people will even comment on how much they love the student. And so it might bring patient satisfaction up. If that student can sit there and listen to that person talk for 10 minutes about, their favorite dog and their granddaughter, which we don't have time to do, that patient satisfaction score is like through the roof.
I
I
always teach our students to always ask about grandkids. Because if you ask them about their regular kids, they're like, sometimes they're like, meh. And then you ask about their grandkids and they're like, my grandkids are the best. And so it's always the best thing. If anyone's like, oh, like you think their grandparent age, like asking a grandparent question is like the best one because people love talking about their grandkids. Regular kids, not so much all the time.
well, 50-50 on that. So to echo those sentiments, absolutely full transparency, it slows me down in the beginning. But I've also found that if I will really invest time with that student at the beginning, to make sure that I'm really getting them prepared to be efficient, it makes us efficient as a team. So I usually like them to come meet me a few minutes early, before the first shift so that we can walk around. I can kind of orient them, show them, hey, this is how the pods work. This is where the bathrooms are. That's a huge little thing that just makes them feel comfortable because I mean, goodness, that just can kind of ease them in. And then other things that I've found that if I will take the time to teach them how to chart, how to place orders, all of those things, then as we move along, it can be like, hey, can you place the Toradol for room 4? Great, they know how to do that. And so then we become more efficient together. I do like to send them to have their own patient and then come back and present. We go and see them together. But something else I like to, especially in the beginning, is to have them come with me to see a patient because I want them to see how I'm asking the history. How am I doing the physical? And we all know in EM there are certain things you ask. Like for example, I always want to know who their primary care provider is if they have one because I'm always thinking like, is this going to the hospitalist or to a different team to admit? So they learn little things like that make them efficient, so that when they go and see patients on their own, they're getting faster and they're getting a little more streamlined.
Yeah, I think another big thing too with efficiency is like how do you efficiently teach, right? There's like the patient load efficiency and then how do you teach, right? Some specialties, right? Like you go back to a student, you had like an hour-long lunch and learn every day. Like we don't have that luxury in the ER, right? And so I think a couple like good tips and tricks is like one, like real time on the go teaching. So right, like every small conversation in a hallway at a bedside, like that is teaching. And I think sometimes we dismiss that as preceptors as being like truly formative, right? But you go and see someone, or you guys are about to see some. What's your top three differentials for a 60-year-old with abdominal pain? Or like, why do you want to order this CT? What are you hoping to rule out or in? And what type of contrast? And all those little bite-sized pearls and tidbits, like stick with them. And it takes less time to digest and then go through later when you're trying to put all your orders in, do your note when you're back at the computer. I think similarly to that, right? If you're teaching around the patient's workup, EM is a lot of like do a lot, stop and wait for things, right? So as you're waiting for those labs, those imaging, like that's a great time to debrief cases. Okay, if this troponin comes back positive, then what would you want to do? Or how do you think this disposition would go if like the patient CT is negative? Do you think that they're still okay to go home? And same thing, those little things, then you can kind of, talk about a certain medication that comes up and there's all these organic teaching moments. And I think, there's natural transition points to debrief. When there's a lull or at the end of the shift, that's a great time to take 2 minutes, find a resource, do some summarizing, or ask if they have questions about things. But don't feel the pressure or the need to, have some deep dive farm lecture in the middle of, a crazy shift where you're seeing 20, 30 patients.
I mean, that's so great, Margaret, because we tell our students that their studying looks different in their clinical year, right? Like you're not going to have 3 hours at night. Well, you might just study, but you're actually studying during the day because you're learning as you're walking down the hall, and then you're asking about the liver functions and you're figuring out what the PT is and all that stuff. Our students can be checking off in their head, like, hey, I really studied liver functions today. I really know these labs because we talked about them. But I think that sometimes they think, oh, if I don't sit down and have something in front of me and have notes to take, I didn't actually study for my day. And it's the same thing about teaching, that you can teach all that on the fly versus like having to have a concentrated time. And sometimes having that didactic is awesome if there's time for it, but in the ED, there really never is much time for that. When you guys talk a little bit about clinical teaching, I want to transition to talk more about that because I think that's like the biggest meat of being a preceptor, and then how to do that as efficiently as we just said, but how to really be a really good teacher for them in all aspects of the day. I want to talk a little bit about just starting off with students. Do you guys set goals with them when they come? Like, is it the first day goals? Do you set it for the day or for the week, the rotation? How does that look when students, like, the first one shows up to your place? They're either eager-eyed or they're blurry-eyed or they're rolling their eyes, one of the three, right? How do you start with those goals?
Yeah, I think that, so first of all, I think it's important to say, like, this is my expectation for you. Having a perception is like, is this your first rotation ever in, your clinical year? Is this you're about to graduate and you want to do an EM fellowship? But I also think at the start of the shift, the way we work is that we have students who rotate with a different preceptor sometimes every single shift that they work. And so I sit down and say, like, what's your goal for today? Is it improving your patient presentations? Do you have a certain procedure that you want to work on? Is your clinical decision making or your medication dosing? And then I also just say there's this really great kind of educational model. It's called the RHYME model, and it stands for reporter, interpreter, manager, and educator. And I use that as a framework for their growth, right? If I always say like my grandma could go see someone with, ankle pain and tell me the history and touch on their ankle and tells me it hurts, right? What makes you different as a PA student and as, an about to be or soon to be clinician is that you can take that history, that physical exam, you can interpret it, and then you can interpret the x-ray results. You can manage those results. Do you need an orthopedic consultation? And so the goal is for them ultimately to get to the point of educator where they're able to educate their patients, they're able to educate other learners, right, about, essentially the case from start to finish. And I think that has really helped students, they're really, really good a lot of times at getting a history and a physical. And then they stop their presentation and I'm like, but where's the rest of it? That makes you, an actual soon to be PA. And I found that that really helps them take ownership of like patient care plans, and really move towards that spectrum that we like to see. Jeremy, what do you think?
Yeah, I think those are great points. And actually, a lot of what I do piggybacks right off of that. I love the hallway conversations. That's kind of my style. And wow, just lost my train of thought. What was the last point you just said about?
You like
Well,
bedside teaching techniques and
yeah. So bedside teaching is something I value, and I think everybody really should. I know I personally experienced you don't get a lot of bedside teaching. And as a preceptor, you think, okay, well, we need to move this out in the hallway or out by the computer, but you're really challenging that patient or that student in front of the patient, and you're providing education to your patient during bedside teaching. And so one of my favorite things to do is say, what do you want to do? Um, if I'm in the room with them, tell me what you want to do. Oh, I want to order this. I think we should give this, whatever that is, but we're right in front of the patient. Then I ask them, tell me why. They didn't have to present to me because maybe I watched them do the interview and physical exam. And just like your second point that you said, it gets them involved in the decision making, which is where they want to be, right? They're super anxious. They've done all the studying. They're freaking out that in less than a year, they're going to be prescribing medicine and doing this alone. And so allowing them to really come up with an answer and to show them that you value their answer. And then it's great because you just ask them, why do we want to do that? Okay, tell me more about why you want to do that. Is there a physical exam that you found that made you come to that conclusion? Let's talk about that a minute. And the patient's watching this whole thing go on. You don't put them in a trap or pimp them in front of the patient. I think that will just kind of shut a lot of students down. But then also, if they seem a little stuck right in front of the patient, you can say, great, that sounds like a great assignment. Why don't you look that up, put that on your notebook, and we can talk about that tomorrow, either during our lunch break or we'll meet 30 minutes before shift, and I want you to teach me a little bit about that. Another thing I like to do at the bedside is teamwork visits. So depending on the strength of the student, right? I think Tanel talked about bringing them in, bringing them into the room. I like to bring them into the room and knowing their strengths and their goals, I say, okay, I'm going to have you interview. I'm going to chart. That keeps me efficient as well, instead of seeing other patients. And then I've seen two or three and I'm dealing with things when they want to present. And now that patient they saw is delayed because I sent the student in. And so I just do the chart while they're doing it. We review the chart together. We have those conversations at the bedside. Sometimes I flip flop. Why don't you watch me do the exam? I want to see how you put the note together because I'm teaching them efficiency as well. Chart at the bedside. Why waste all that time walking back and forth and sit in the chair when you got a computer right there? You can use your tools. And then, of course, I tailor it to their goals, right? So do they have an interest in EM, or really they want to go into plastics, so they're here for procedures. So I might tailor the bedside teaching to definitely skills that they're really wishing to gain.
Mhm.
I
Jeremy,
How
love
about
I
you,
haven't
Tanel?
been in the, I
Oh,
haven't been a student for like 23 years, but when you said, hey, why don't you write that down and look it up and tell me tomorrow? Like I was like, ooh, I started having a panic attack because I
Like
feel like I
baby's
spent an entire year
palpitations.
just writing things down in my notebook and putting it in my pocket and looking it up for tomorrow. So I had a little flashback to my own precepting, my own days as a student. It's like, how many times did we all get told that, hey, why don't you just look that up and tell me tomorrow?
yeah, right. Well, one of the things I love to do too is I usually give them a couple of night shifts, and night shifts often have some downtime. And so I will tell them to pick one of the cases that they're most interested in. Tell me about it. I want you to give a 5-minute presentation to all the nurses and techs and docs, whoever's here. If we don't have any patients, if it's slow, we'll gather up in the main pod and student Brendan will give a presentation on DVTs, and then the nurses ask them questions, and it's scary, but it gives them responsibility for teaching something back to their teammates.
I love that idea though, Jeremy, because I think truly sometimes we forget because we picked emergency medicine that this is a really polarizing rotation for a lot of students, and some of them are absolutely petrified. Which actually, truth be told, that was me. I was one of those that I was absolutely petrified. I wasn't particularly interested in emergency medicine, so I always like to kind of gauge like where they are in that spectrum and kind of wanting to know what it is that they particularly want to do. And I think that whenever they come to me in general, depending on where they are, for the most part, unless they are also doing an elective emergency medicine rotation, this is their first time to be in EM. And I find that there's a little bit of they struggle to kind of change that primary care mindset to be thinking from an EM mindset. They'll tell you, they're like, I want to order a PSA. And I'm like, no, sweet babe, no, we're not going to do that. And so I have found that when I have a student that's particularly struggling from like thinking primary care to going to like, nope, let's think about emergencies. One of the things I like to do is I'll have them go see a patient. I say, cool, give me your top 5 differentials. And then I want you to write those out and also write out the actual things that you want to order that are going to rule these things in or out. And then that way they can kind of present it to me because I think it's important to get down the skill of verbal presentations. But I'll be honest, it's chaotic sometimes, and they will have told me they wanted to order a dimer and I've missed it. And so it's sometimes nice to have something we can both kind of go back, look at. And I have found that also kind of helps them round out their understanding of like order sets. So when they are actually putting in orders, it kind of connects the dots of like certain workups we do for certain chief complaints. And I have kind of found that bedside teaching helps them kind of go from the primary care to like why we're not getting the PSA.
Yeah. I think those are all amazing ideas. Those are things that I do. Jeremy, thanks for like bringing up the charting in the room. I'm like, duh, why don't I do that? I had never considered that. So even I'm learning 17 years in. So thanks for the tip. One of the things that I like to do that's really fun with the students is I really want them to learn how to differentiate sick versus not sick. I feel like students have a lot of trouble doing that because I think their initial thought is like, well, if they weren't sick, they wouldn't have come here. And I'm like, well, that's the first rule of EM is that not everybody who comes is actually sick. But one of the things I'll do with them is we will literally just walk around the department and we will stop at the doorway of patients we aren't even seeing. And I'll say, sick or not sick. And I just want the students to like start getting a gestalt for like, how does a patient look? What is their general appearance? Like if they're hooked up to the vital machines, taking a look at numbers, but just getting a feel for it. So sick versus not sick is a really fun game I like to play. I don't know if anybody else has any other random ideas.
Yeah, something that's a little atypical, and it took me a long time to get here. And I have to say, like, my institution's been super supportive in kind of doing this, is that some students I think really do well with like a asynchronous or like didactic component to go along with their clinical learning. I always tell people, you work an entire month straight every day in the ER, you might see a dozen STEMIs and strokes, and the person who's working the morning or the AM shift or something might not see a single one for the same month. There's so much like luck of the draw to it. And so you still want them to get those core foundational topics, right, of ACS and stroke and all these other things. And so this was a huge undertaking for me, but I found that my students really love it, is that I have this Google Classroom set up, which took a huge startup cost, but now it's completely asynchronous. And I say startup cost in terms of time. Google Classroom is a free resource. But like, so I have like modules, like week 1, how to give a presentation to the ED, and like to an ED attending or whatnot, how to write a note. And I think we're in this age where there's so many great open access resources for learning, that a lot of it I haven't really had to do my own content. There's foundations and Core EM and all of these great things that have podcasts and blogs, and we talk about different types of learners and those really engage them. I think that, that sounds again like a huge undertaking. Sometimes what I would do before this is I would think of one topic, right? If we had a end stage renal patient, I would send them, a blog post on hyperkalemia at the end of a shift or something like that to their email, and just give them something to do a little bit of what I would call a deep dive in. And along with that too, sometimes your institution, or if you're affiliated with a university, might have resources for like doing a boot camp or a procedural skills workshop. And it's a great way, I think, to also further kind of professionally develop yourself or your PA group as well, and get more opportunities for learning and teaching, which is really great. And it gives you, I think, more time too when you know they're doing supposedly this like pre-learning or other stuff to do some higher level reasoning at the bedside, when you are confident that that foundational concept or learning is there.
That's awesome. Okay, so far I've learned that I want to walk around the ER with Dana to play sick or not sick, and I don't want to work a night shift with Jeremy because I just want to like eat a Three Musketeers and like veg out and not give a presentation to everybody on DVTs. Okay, I'm learning as we go. I think one of the things that has students, we give them a lot of feedback when we're in their didactic year. They get a lot of feedback from us as their advisor and their faculty. But when we throw them out into the clinical world, we really rely on the preceptors to tell us what's going on and to give feedback to them, because that's who's shaping them to be a future PA, and feedback to the program to figure out like, hey, how's Susie doing? How's Jim doing? Those kind of things. So it's really necessary to give feedback. It also can be really hard because people are generally really nice, and Jeremy and I both live here in Iowa City, and in Iowa, everyone's nice. You just want to like say nice things to people in the Midwest. But we really have to be able to give good feedback, constructive feedback, hard feedback, all different kinds. And so what strategies have worked for you all to give real time feedback as well as kind of constructive feedback during the rotation?
Feedback is so hard because I'm personally conflict averse, which maybe many of us are, but I just hate when I have to give them something constructive. But something that I think is really important to remember is that you're protecting the PA profession if there is something going on. And if they really need to, they're not where they're supposed to be, to give the feedback to them and then maybe even to the program, is that you're protecting our profession, you're protecting the patients that they're going to care for as well. And so reframing that, because I think giving good feedback is pretty easy, right? Like, you're doing a great job, your meds, but I think giving the constructive criticism is a lot harder. I tend to give feedback the whole rotation, and then at the very end, we sit down and we have like a one-on-one, and I have them give me feedback and feedback for the rotation, and then I give them their feedback, and then of course we do the formal eval as well. The other thing you could do is like flip it on the student. So, how do you think that this went today? How did this patient encounter went? What went well for you today? What do you think you could work on for tomorrow? And really having them kind of think of it rather than them just like listening to whatever you're telling them, to actually critically think, which we all really should do about ourselves.
Yeah,
Ashley,
I
when you
think
ask people that, sorry, when you ask folks that, do they say things that they perceive that went poorly that you didn't even notice, or that you thought like, hey, I thought you did a fine job, but they're actually more critical with themselves? Do you find that?
Oh, for sure. Or they have such perfectionistic tendencies, and I can tell that that's where they're shooting for. And I'm like, I do not expect you to know every single differential for this and to know what medication. Like, that is not that was not a miss by any means. You still nailed it.
Yeah, I think too, then you kind of have like the other side of like the overconfident student who like thinks they're ready to like practice in a solo ED by themselves, right? And so you have this like weird balance of, you want to be encouraging, right? But I think you also like, it's very important to put up guardrails. Like, I always tell my new grad PAs when they start in the department with us, one of your best skills is knowing what you do not know. Like, you don't actually need to know it. You just need to know that you don't know it. And that's a fantastic skill to have. And so I think that there's like, validate their enthusiasm, right? But also like redirect them and kind of probe and challenge them. So like, walk me through your differential with that, or like, what risk or complications like do you foresee for that like if you do that procedure? And the goal is then to like help them recognize those knowledge limits and gaps, rather than like shutting them down, and making them feel incompetent. Um, I also think it's important, like, make your expectations for supervision super clear. Sometimes, you're documenting at your computer and you hear like the student saying like, this is what's going on with you, blah, blah, blah. We're going to do X, Y, and Z. And I'm like, okay, we got to reel it back in of like what our expectations are of like what you should or shouldn't. And, and that's kind of just I think a good hard and fast rule, because like things are dynamic and change, and then it's hard to build trust with the patient. Also remember sometimes that life keeps going on outside of P school for a lot of these, students. I would say kids, but like they're not kids, right? A lot of these are like adult learners, obviously. But like sometimes I'm just like, what? Like, the student is like so disengaged and off, right? And I've had multiple times where you find out like a family member died, or I've had a student who like was a like witnessed a code on the side of the street and had to perform CPR, and like that was very traumatizing. Or even what we see in our own ERs, right? A lot of us are used to a code, a trauma, a this, and it might be the student's first time ever experiencing that. So don't forget to check in and ask, like, are you good? Do you need to take a breather? Have you had this experience before? And, nowadays, a lot of both kind of hospital institutions as well as academic institutions have so many resources that we can also provide for, students if that is something that they're struggling with, that don't forget that could be a contributor to maybe why you feel a student might be disengaged.
Yeah, that's a great point. I mean, our threshold for like what's a bad day and or what's a traumatic event or what's traumatic things to our eyeballs is so different than like the average person, right? Which is why we like don't have real friends and we only talk to each other because everything we see is weird and crazy and people think we're strange. But for students, at the first time, not even like a dead body or a CPR in progress, but a weird amputation or a half amputation or a finger half off, like all these things that were like, well, it wasn't totally off, like it's just kind of off, like, but that could, I mean, that's all can contribute to that feeling. So I think even thinking of stuff that we didn't even think would be traumatic, like especially extremity injuries and things, to like check in, like, hey, everyone okay? Like you're feeling fine. You need to take a little bit of break. Like you want a granola bar and sit down. That could be a lot, even though like we're pretty used to seeing it. So I think that's really great advice. What about feedback when you think like, okay, there's something not right with a student. They're either not where they need to be or something's going on that I think their PA program needs to know. I don't want to be a tattletale. I don't want to cause them to fail. I think that's the concern as a preceptor. If I say anything, if I call their program, they're going to fail them or something. I'm going to delay their graduation. When do you feel like it's time to reach out to the PA program? And what about like doing like midterm evals versus final? Like where can you help in that? And then again, when you ultimately have to reach out.
So I think there have been a lot of really good tips about checking in each day, checking in for the week, setting goals, things like that. But one of the things at my program, because I'm an assistant professor at my program, and one of the things that we noticed is that we wanted to give students and this has been touched on, like the opportunity to reflect on their own performance. So we created a mid eval, and I'm happy to share that form because that's even something you as a preceptor could bring to your student and have them do, where essentially they're kind of assessing themselves, like, what am I doing well to this point? What do I need to work on? And then creating 3 goals that then we kind of go over together. Because ideally, I want to have some checkpoints for them before we get to the final eval, especially if they're struggling, to kind of reroute them if you need to, or to give some guidance. But truly, if you're ever in doubt or if you're concerned, please reach out to the program, because I can tell you from a program perspective, we would rather intervene early and get them back on track, or make sure that this student is where they need to be, than finding out after. So I would say, just if when in doubt, reach out.
That's awesome. Jeremy, I'm going to put you on the spot here too, and Margaret, because I know that you guys both have really great like orientation type practices. I know everyone does, but I do know particularly you do, Jeremy. Can you tell us a little bit about uh, how you structure your orientation? Like, do you send a welcome email? Do you meet them early before the first shift? How does that day look like? I remember, like, I feel like at school it was like, hey, I'm Katie. And they're like, okay, that's awesome. Go see a patient, which I know wasn't what happened, right? But in my head, I feel like it was. So, can you tell us a little bit about how that's worked for you?
Yeah, thank you for asking that. I had those experiences in school where I didn't meet my actual precept till the fourth day, my preceptor till the fourth day, and it was mortifying. I also learned a lot from that about being a self-starter and stuff. So there's learning in all of these ways of doing it. But I developed a sort of informal email that I copy paste tailor to each student over the years. And I go through, it's super long. I greet them basically. I start with a greeting. Who am I? This is going to be a long email, so take your time and go through it. I want to get to know them. So I typically then ask them questions. What have you completed? What's your prior experience? What are you interested in? What are your strengths and areas for improvement? What are your expectations and what you hope to get out of this rotation? And then any concerns or fears about the rotation. Because I want to know who my fainters are, who is really terrified they're going to see a dead body. I want to make sure I'm sensitive to that all the time, but it's nice to know that ahead of time. So getting that kind of out there. So right away, I start by saying, answer these questions. I share them with the group, or because I'm not always the only one that precepts them when they're with me. And so then they have a chance. So then I share that response to the group. Sorry, kids are FaceTiming me. And then I tell them about who I am, a brief background. They don't need to know everything I've done and all the amazing accomplishments or whatever, but who I am, where I'm from. I want them to know I'm a real person. I give them information about who they're going to be working with. What's our group like? This is a private practice. This is an academic center, depending on where I'm at. And this is sort of how things are managed, and you'll see that when you get here. Talk about optional opportunities. I had a second job that sometimes I would take them to if the program would allow that to be set up, but not put it on the schedule unless they wanted that experience. For example, I used to work for a private group and knew that some of the students really wanted to do the ED residency. So I would work with the residency folks at the University of Iowa. I worked there a few days a month, and they would allow me to bring the student in for a couple of days and work that shift with me. So then I could introduce them and sort of get them their like interview and talk with the people that make the decisions, because it's not me who picks them for that. I go over the site details, address, maybe tips and tricks on how to get there, because I know if you're coming from Iowa City, take this way, even though MapQuest will tell you this way. Where are you going to park? Right? What are meals like? We don't have lunch breaks. I will allow you to have a lunch break. If you bring a lunch, I'll show you the fridge. Otherwise, there's a cafeteria. This hospital doesn't have a cafeteria. This hospital, the food is free, so don't worry about bringing anything, only during these times. So all the secondary sites. Sometimes I put map links in there. Then I talk about my expectations, right? Professionalism, learning approach. This is sort of what I expect for you. For learning, what you're going to wear, right? Your program may have rules, but this is what we expect at a bare minimum. Patient care tips. I give them tips on how our group likes to get a presentation, and what format they should use in case it's different. Because I don't know how many of you get that where they present to you and you're saying, actually, can you try it this way? Well, that's not what they taught me. Or you're like, okay, great. Well, they're at the program, not in the real world. So let's do it this way. Then I talk about what they should expect from us. These are my commitments to you. We will treat you with respect and so forth. And then I give them their schedule if I've made it. Or sometimes it's ER, it's flexible. I ask them for any days of concern that they may need off, but I'm not guaranteeing it off. They can give me that. Interestingly, I've had some students reply, well, I would prefer to work days Monday through Thursday. Oh, I'm sorry. Was I
Oh, me too.
unclear?
Me too.
Yeah.
And you just laugh and you're like, no, this is ER. You will work nights and weekends and a holiday if you're willing. Because holidays are the most fun shifts for students, right? The most lax and broken bones and stuff like that. So, and then I close, give them next steps, and give them that info. But I really like to meet them an hour or 45 minutes before the shift. To do a formal orientation, because I've tried so many times. We'll spend the first 30 minutes of our shift doing an orientation, and that just happens to be the day the department is slammed and you're like, yeah, hi, nice to meet you. We're going to go see patients. Follow me. And so I usually meet them an hour early before, and I give them the tour. I introduce them to the nurses in the pods. I talk about that, like what they do in each area. I talk about flow with nurses, get them comfortable seeing me interact with the team, so they're comfortable going to them and saying, hey, you know what, like, I want to start as many IVs as possible. Would you be willing to come and grab me if you're going to do an IV? And then they get that relationship, if they want it. I'm not forcing them to do it. Definitely show them the bathroom, show them the secret bathroom, so they can go in private, not the one that's like in the ER, and how to get there. Show them the cafeteria, walk them all these places, say hi to people along the way, and then give them a chance to reiterate some of their expectations. I go over my commitments again and ask them if there's anything else they expect from me that I didn't include in the email, and we can make sort of a pact about that. Again, if you don't set time ahead of time, it sucks because I'm not getting paid for that, but it makes it so much better because you can capture things that you may have missed. You get to know that student better, and it just flows so much easier. And then the first time they see a patient with you, they know what's going on, and it seems to go a lot smoother. Was that way too much talking?
No, it was awesome, and I have two questions for you. The first question is MapQuest still a thing? You said that the MapQuest, I don't even know if it's still a thing anymore. Someone Google that for us. Is MapQuest even a thing anymore? Jeremy's printing out his maps on his way to places. Okay, anyhow. The second question is this is awesome. A week before, do you send this? 3 days before, the Friday before? What's your timeline? What's your timeline usually to send this email out?
Yeah, so the program typically they use this exact thing. So it sends you an automatic reminder at 2 weeks before. And I do my best to get it out then because typically 1 to 2 days later, you will get an email from the student saying, hey, I'm reaching out because they're supposed to hear from us, right? Are you my preceptor? And you're like, crap. So I try to beat them to the punch. So typically 2 weeks, if not at least 1 week.
Awesome.
Yeah, I do a lot of the same stuff. I have a like a handbook. And actually like SEMPA and Hippo have teamed up and we've got these templates too. So those are resources that we're going to work on making available to you guys that we're really excited about after this. Two things kind of outside of the handbook welcome email that I found is the way our site works is my group staffs 4 emergency departments. And so at any time, the university that we're affiliated with, I could have like up to 10 students essentially. And so I found a like 45-minute, 30-minute Zoom orientation like the night before or like the day before their first day, where we just go through essentially everything that we put in that welcome email and handbook that they probably didn't actually read also is like a good idea. And then it just is like a space for them to get out all of their jitters and answer their questions. In addition to that, too, we do kind of like a boot camp day their first week, which again, if you have the resources, do it. I think has been super, super great for our students of like what is medical decision making and how do you do a patient presentation, and we workshop EKGs. I have a lecture on like common emergency medicine medications because students come in from like their primary care rotation right before, and there's just like this disconnect when you go from Friday to the next Monday doing one of those things. And so I found that to be super, super helpful.
Awesome. What about resources? Do you guys recommend certain resources? I know there's a zillion apps and guides and podcasts and things, but are there some that you recommend that your students use for your rotation?
Well, now I'm going to use all of Margaret's resources because I'm really impressed with everything that she's put together. So I'll definitely use whatever is provided after this. As a Hippo employee and lover of Hippo, I do have to plug our Hippo AAPA rotation crash course, which Katie Iverson hosts. So you get to hear Katie, or the students get to hear Katie. So I always have them, for me, listen to the family medicine rotation, but of course they could listen to the EM rotation podcast. It's short. It gives like tips and tricks. And then, certain apps like Hippocrates, MD Calc, Emory Antibiotic Guide, iChart, Peds Guides, lots of different apps that we use. One thing I wanted to bring up that's happened just this year for me is that students are using AI, particularly open evidence, because I guess they can get access even without like the NPI that we have. And so just keep an eye out for that because I found some students lean more heavily on that, and I'm a little bit worried that it might take away some of their clinical acumen. And so I would watch out for that. I don't think we need to discourage it. I definitely use it sometimes, but like you need to vet your information before you present it to me or write it in the note.
That's awesome. Okay, we're going to wrap up here real quick so we can get to some questions that folks have, but I want to touch a smidge on CME for precepting. So I know that people have questions about that. So I know that like category 2, you can get precepting CME for category 2 for NCCPA, just like journal reading. Like I read JAPA for 3 hours. I had Jeremy in the ER for 3 hours and get 3 hours of category 2. But what about category 1? How does that work?
Yeah, so when I precept, the programs send me a CME offer. So the program has to be registered. They go through a different system. They have to be able to grant it, and the AAPA gives them that ability. Okay. So really, you just ask them, do you grant CME? You'll get your survey at the end of the rotation, just like you would do for any other Category 1 CME, and they will give you now it is 2 credits per student per 40-hour work week with no limits. So you can get all your CME precepting. I mean, that's a lot. That's a lot of precepting, but you can certainly do that. What else do we need to know? You just, yeah, contact. And then of course you can just bypass it if you don't want it. But yeah, 2 credits per student per 40-hour work week with no limit.
And that comes from the program. So with any questions or any doubt, contact the program that sent you, Susie, to the ER and ask them if they do this. That's right. They have to be signed up and established.
Yes. And it does get a little bit hard when you share students. And so for a while when it was first going on, I kept getting all the CME, even if I was on vacation and one of my colleagues did it. So I started keeping track so then I could send the program, hey, I think they can only do one. It depends on how the program is set up and if they have an administrator that can do that. But I would say, would you actually list so and so as the preceptor so they can claim the CME for it? I don't need it. And then they would do that for me.
Awesome. You guys, this has been so great. We've learned so many things. We want to live where there's daisies that come up. We want to go walking around with Dana to talk about who's sick and not sick. We want to just be in Margaret's ER and be in her Google Classroom and all the things that she can teach us. This is, as we said at the top of this is the way that we advance and protect the PA profession, because if we don't precept, who's going to precept? And we really want to make sure that our profession stays strong and that we move forward into the future, and we are responsible for part of that with precepting. So we really encourage folks to precept and to be that one that you remember like 10, 20 years down the road, that one that sticks out to you because they were such a good teacher, or they were so compassionate with their patients, or you learned such a great physical exam trick from them or something. So as we go into the Q&A, we're going to go real quick around and we're going to shout out the preceptor we remember from how many ever years ago it was that was really important to us. Margaret, you're up first. Shout it
Yeah,
out.
Dr. Darren Flamick from Baptist Health in Little Rock, Arkansas.
Awesome. Dana.
PA Linda Carr at Porter Hospital in Denver, Colorado.
Awesome. Jeremy.
PA Tracy Allshouse, family practice in Cedar Rapids, and Dr. Allgood, general surgery in Mason City.
Oh, Dr. Allgood, my heart. I had him too. Ashley, how about you?
PA Stephanie Blodgett, Olympia ER, Los Angeles.
Okay. Tanel.
Dr. Dan Curry at Texas Children's in Houston, Texas.
Awesome. And mine was Dr. Schillhammer. He was a family practice doc in a little mountain town, logging town in Darrington, Washington, which was a great rotation. Okay, let's go. I got some questions here that people have asked, and we're just gonna kind of go around, and if you have the answer, jump in, and then we'll go through. Someone is asking, with my affiliated program, I have one student with me every shift for 6 weeks. While I love it, it feels like a ton of mental energy and I find it exhausting. I am also exhausted reading your question about someone every shift with you for 6 weeks. Any tips on how to keep it sustainable? Any preceptor self-care that you guys would recommend? This is really a great question.
I'll just jump in. So actually, and I create their schedule, so I guess it's a little bit unfair, but I give them 12 shifts over their block. So that I try to keep it equitable, because that's really hard to keep up that momentum. And I try to look at my own schedule because they work what I work. But if there's a particular time that I think like, hey, that's going to be my 5 out of 5, and I'm going to be emotionally exhausted and probably at the end of my rope, maybe that's when they don't come with me. So if you have the opportunity to kind of curtail that and say, hey, actually, you're going to work this exact schedule and you have some solo shifts, I find that kind of gives me a little bit of breathing room, and kind of gives them some downtime as well to think about, hey, that would be a great time for you to study or whatever that might be.
Yeah, I think too, like a lot of times, right? And it's totally depends on what your shop is like, right? You might work at a level 1 trauma center with 15 residents and 4 attendings and 5 PAs, where it's, there's someone for them to like buddy up with. I also think it's important for them to like learn those other roles of like, what does a resident look like in the ER? What does an attending? Sometimes I'll have them do a half a shift shadowing with the nurses to practice IVs and do all of these things because those are skills that they like don't always practice and it gives you a breath. I also had my favorite preceptor, Dr. Flamick. He described something to me called the sterile cockpit. And it's this concept from aviation and flying that when you're landing, like there is no distractions, like no one is talking, right? Like it is a sterile environment. And so whenever he was discharging patients, right, that's like the first thing you do in the ER is like get the patients out. He was like, I am in my sterile cockpit. And so I think establishing some of those boundaries too, if you are in a solo shop and you can't, I don't want to say offload your student, right, but create that breathing room, just coming up with very clear kind of boundaries of like, this is when I say this or do this, or this is a task I'm doing. It is like not a personal thing, but I'm just going to try to focus and do this uninterrupted. Because meanwhile, the students like they think I'm not doing my job, they're not doing all these things right, and they're super insecure about it. And I think setting those expectations before can be really helpful with them.
Yeah,
Oh
you
my
know,
gosh,
I
sterile cockpit. I love it. I love that. I'm using it
as
with
I
tonight
hear this
tonight.
question, oh my gosh, wait. So it sounds like that's coming from your program, and it's hard, but you have to take care of yourself. So this program, you get 4 students a year. Once other programs start to hear that you're available, you could have 2 students with you all the time if you let them. I finally at one point said to the other 3 programs in the state, I only take Iowa students. I have enough. I have colleagues that can do that. And that worked out. But unless you are extremely organized and that is your thing, you need your you time. At least that's my opinion. And so I would set boundaries with the program. I can only take so many and then give yourself a month or 2 off to kind of get charged up.
That's great advice. What about still keeping a student? We have a question about keeping a student's learning and experience really high level when um, patients may not want to have a student. So how do you kind of balance the patients like I don't really want to have a student and making sure that students are learning, seeing patients and doing procedures that maybe they don't want a student in on. Have you guys faced that and how do you kind of do both?
I think sometimes telling them that that's like life. Like, how many times as a PA have you seen someone that's like, I don't want to see a PA, I want to see the medical doctor, right? Like, that's a reality sometimes of what we like navigate to in this. And so sometimes students can take that very personally. And I think it's an important lesson to say, like, this is something that probably you'll continue to face in your career, unfortunately, and help them explain a lot of times it's not personal. There might be some sort of implicit bias, which is also unfortunately the reality of what we live in. But I think too, that's like a really great time. I think back to some of the things that I remember as a student. It's when a preceptor was like, asked me a question, I didn't know it, and was like, go look it up. And so that's a good opportunity, right, to kind of do something a little more asynchronous, right? Give them a task to do, something to perform, read about this procedure. I'll like pull videos up on my phone, right, of from MRAP or Hippo or whatever it happens to be of saying, like, watch this about this procedure. Even if you're not able to do it, it's really important to know. And then that gives them a little bit of a simulated experience, even if they're not getting it. So you kind of get the teaching from the psychosocial, very important emergency medicine side that we see so much, right? But then also the core curriculum component of it too.
Sometimes I think it's about the support staff as well. And so if your nurses are involved with the students, they know the students are there, your techs, they can kind of build it up. Like, hey, we've got this great student. They're just going to come in and chat with you first, and then the provider will come in. Is that okay? And then they're really prepping them. And they're like, the provider's still going to come in. We're not flying blind here. Or if they're not comfortable, like, is it okay if the student just comes in and just listens and learns? So I think it's like setting the expectations for the patients as well that this is what it's going to look like while you're here. We're not just like throwing you to the students and they're just going to figure it all out on their own.
I think something else that I've noticed, like if I'm looking at the board and let's say I have a student that I know can suture and they can suture well, if I'm kind of choosing like, hey, I know I want them to be able to do this procedure, or hey, we've already seen 5 chest pains today. A lot of times I'll pick up the LAC and say, hey, go see that patient, so that that's their first point of contact. Is that the student comes in and immediately starts developing that rapport, which I found is more effective than me going and seeing that and then bringing my student in and being like, and guess who's going to sew up your face today, So a lot of times, like if they go first and kind of establish that, then when I come in and we, talk about it together, that's kind of a way that we handle that.
Yeah, I think I do the same thing. It's not a clinic, so I don't have somebody asking the patient permission. Do you want to see a student? It's kind of expected. You might. And so I work on that student's introduction, right? Who are they? What's their goal? Who are they working with? And just start the visit. If the patient then voices concern later, fine. You can manage that. But it sounds like, I don't necessarily give them the opportunity to say no students, unless they disclose that first.
Yeah, we have a phrase that when I was like getting like I was like establishing my OB care, they're like, we are an academic institution and learners are part of our mission here. And essentially we're like, if you're not on board with that, like find care else. Obviously, like that's not what we're gonna do, but I think establishing that and kind of defending your students that this is what we're doing. We are a learning institution, we train. It goes a lot to build your relationship with the student as well.
Awesome. Um, Another question we had was, do you guys ever ask patients for feedback of the students that they've had as you're like getting feedback or thinking of the day was going? Do you ever ask patients for feedback on the students?
Absolutely. Yeah, especially when they first come in. If you're doing teamwork, if I'm like, okay, you chart, I'm gonna go confirm what you just said. How'd he do? And I give them the opportunity. And most of the time it's good. Sometimes they're like, he was awkward. I'm like, great. So then that allows me to have that conversation. So how do you think it went? Tell me about it. Okay, interesting. I don't tell on the patient because then that makes it weird. But yeah, I do that a lot.
That's awesome.
Hey,
Oh,
I
sorry.
don't know if you saw the other question about burnout, and it just something came into my head about that. I would get the same feeling sometimes. You show up at a shift and you didn't know you were scheduled as a student, and so it just takes you aback, and you're like, oh gosh, I have a student. Or maybe the student's not as easy as some. Talk to your colleagues. Say, hey, I'm going to see this patient. Would you mind finding something interesting and taking this guy for an hour, or just to do one case with, and then I'll take him back or whatever, to give yourself time to catch up. I've gotten so behind precepting before. I've had to ask my colleagues to help me out, and usually we all have those kind of low acuity cases that are procedural that students just geek out about. And so my colleagues will say, hey, I have this procedure. Can I have your student for it? Yes, please. And sometimes that gives you some breathing room.
Yeah, that's awesome. Do all of someone asked about facilities that don't grant students EMR access. Do you give them, if you've experienced that, do you give them yours? Do you like log them in under your own thing so they can chart? Or do you guys all work at a place where students have EMR access?
I've had both. I've worked at sites where they do and where they don't. And for the sites where they don't get EMR access, I've created a template for my note, and then I will email that to the student and then have them open it in their email and still document that note and then send it back to me so I can cut and paste it, because I still want the student doing charting. I need to see what they're working on. So I create that template and I hand it to them. As far as like procedures or orders and things like that, I will have the student come into my EMR in those situations and go ahead and do it. But it might just help you if you just create your own template and send it to them.
Oh, that's a great idea.
That is brilliant.
Awesome. Thanks.
Yeah, so good.
Like, why have I never thought of half of these things before,
Oh,
right?
that's why PAC, DMSS, PAC.
Yeah.
Dana has a PA twice in her name. I'm not even a PA at all, obviously. People figure that out, and Dana gets to be one twice. It's not even fair. Okay, we're about done with our time. It was great to talk to everyone. Thank you, folks on the panel. It's been really fun to prepare this with you and to share it, and everyone on Zoom for joining us. I mean, I've learned so many amazing things, except, I mean, I'm obsessed with a sterile cockpit. Like, I'm going to do it with my kid. Like, yep,
Yeah.
mom's in sterile cockpit time. Am I reading a book and drinking Diet Coke? Perhaps. But I'm in my sterile cockpit. Do not bother me. For those who join us or here live, you'll remember you get the email tomorrow about information about how to get your CME credit from this webinar. And we will also have a link to our Hippo SEMPA partnership and the product discounts that we have through that. If you have any questions at all, please reach out to me at pa@hippoeducation.com, and I can get in touch with all of our panelists. If you would like Margaret's giant welcome guide as an example, I can email that to you as well. If you have any questions, if you want to see Jeremy's orientation letter, we can probably get that out to you as well. And so please email me with questions or issues as you have. And again, we just are really thankful that you joined us, and we hope you learned a lot. We all learned a ton. So the 6 of us have lots of new things to take on our next shift with our students. So we're really thankful. You guys have a great night.
Thank you so much.
Katie, thanks everyone.